Hi, my name is John Broach and I'm one of the emergency medicine physicians here at UMass, and I'm going to be running the Mass Casualty Incident and Life-Saving Intervention Station, and I wanted to go through a few of the concepts that we're going to be talking about and using in that station so that you can get the most out of the experience. To begin with, a mass casualty incident, or MCI, is any event that creates a large number of casualties, and specifically a number of casualties that exceeds the available resources to care for them. That could be a two-car MVA if you're talking about a small community with limited resources, or a terrorist bombing or natural disaster with hundreds of casualties. The key is that it all depends on the available resources and the number of patients that you need to treat. The key focus shift is if you're in a mass casualty incident, you shift from doing the maximum good for each individual patient to doing the greatest good for the greatest number of patients. The way we do that is by assessing who can benefit most from the resources that we have available. One way that we do that is using triage, and the most commonly used triage protocol in Massachusetts is called Simple Triage and Rapid Treatment, or START. The goal of START is to spend 30 seconds or less on each patient and put them into one of four categories: green, yellow, red, or black. That's based on the assessment of their breathing, circulation, and mental status. The way START triage works is that the rescuer begins by telling everyone to walk toward their voice or to a safe area. Everyone who does that is assumed to be a green patient because they're awake enough to understand the command and they're healthy enough to be able to walk under their own power. The rescuer then assesses everyone else. They start by assessing if the patient is breathing. If they're not breathing, then they're dead, and you move on. If they have any of the following characteristics of their physiology, then they're made a red patient. Even one of these is enough to make you a red patient. If your respiratory rate is greater than 30, if your cap refill is greater than 2 seconds, or if you have an altered mental status. The mnemonic that we use to remember this is 32 can do, or 30 respirations per minute, greater than 2 seconds of cap refill, and can do, in other words, can follow commands. Everyone else, those who are not dead, not walking, and not red, are yellow. This is, again, not based on the type of injury that you have, only on physiology and the presence of those key three indicators. Life-saving interventions are an additional step. They're beyond the scope of START triage, but that's because START triage is designed to be used by any level of responder. Life-saving interventions are incorporated into other triage algorithms, and we'll teach them in our station because you're all going to be physicians and they're all going to be things that could be in your scope of practice someday. I want to stress, though, that you should only do things in real life that are within your scope of practice, so if you don't know how to do one of these things, you shouldn't do it. So what are the life-saving interventions? Well, these are things that won't slow you down, they take less than 30 seconds to do, and can save someone's life. The ones we're going to talk about in this course are basic airway maneuvers, needle decompression, stopping bleeding, and the use of auto-injector antidotes. When doing MCI triage, you should never do chest compressions, intubate, place an IV, give medications, do ACLS, or any of the other complicated medical procedures that you may be capable of doing under normal circumstances. Remember, if you're in an MCI, your focus is shifted from doing the maximum amount of good for each individual patient to doing the maximum amount of good for all the patients. Each of these things take way too long, and they may cause you to prevent you from giving aid to another patient while you're trying to take care of someone who may not benefit or who may be too sick to benefit from the resources that you have. So the first thing you can do are airway maneuvers. In MCI triage, you can perform only basic maneuvers. Again, not intubating, not placing advanced airways. These are basically a head tilt chin lift and a jaw thrust. And in children, you can give a couple of rescue breaths if you think that may help. So we're going to go through a little bit of each of these maneuvers. And in the course on the day of the event, you'll be in the life-saving intervention station, which will go through these in detail and allow you to have a chance to practice each of them. The head tilt chin lift is exactly what it sounds like. Basically what you're trying to do is lift the tongue and the soft tissues of the airway off of the airway itself and allow air to move in and out. You do that by lifting up the chin and tilting the head back so that the tongue and other soft tissues are lifted off of the airway. A jaw thrust is another type of airway maneuver that essentially tries to accomplish the same thing, moving the soft tissues off the airway, but should be used in patients that have potential neck trauma or where you're concerned that you may injure their C-spine by doing a head tilt chin lift. We do this maneuver all the time in the emergency department, and it works very well to open people's airways. The next life-saving intervention is called a needle decompression or needle thoracostomy. This is where, if someone has a tension pneumothorax, as is not uncommon in blast injuries or other mass casualty incident events, You can use a 14 gauge angiocath to open the chest wall and relieve a tension pneumothorax. You do this by placing the needle through the chest above the third rib in the mid-clavicular line and removing the needle to allow the catheter to stay in. Again, we'll go through the details of how to do this, but the point of this video is to just let you know that this is one thing in your bag of tricks that may help save someone's life. It's very quick to do, and the result is immediate. The next thing, and perhaps the most important of all of these life-saving interventions, is control of bleeding. We'll be talking about how to use a CAT tourniquet or combat application tourniquet in the course, but anything that will stop bleeding is part of this sort of larger group of measures that you can use to control bleeding. Tourniquets are a very effective way to do this, and there are many commercially available types of tourniquets that you can use to control bleeding. We'll talk about the ways that these are applied, how safe they are, and the characteristics that make a good tourniquet in the course, but for the time being you should know that this is one of the things in your bag of tricks. Finally, we're talking about auto-injector antidotes. Specifically for this course, auto-injector antidotes are going to refer to those medications that will be used to treat nerve gas intoxications. Traditionally, these are atropine and pralidoxime chloride, or 2-PAM. These are used for nerve gas exposures, nerve gases being those family of intoxicants including VX gas, sarin gas, Tobin gas, and others. The reason these are important is that nerve gases may be one of the commonly used agents in terrorist attacks, and we'll review how to use these auto-injector antidotes and the symptoms that would be indications for their use during the course. For now, you can review the effect of nerve agents on the body, and these are some of the main symptoms. People have runny nose, may have difficulty breathing and eye pain, blurry vision, change in vision. These are all more minor symptoms. Sweating, they eventually will progress to diffuse muscle cramping, muscle tremors, almost appear to be having a seizure, and eventually will be in a coma and die. Nerve agents are obviously very dangerous, and that's why auto-injector antidotes are potentially very useful things to have as part of an EMS or first responder kit, and things that you may need to use in the hospital as well if you're ever involved in treating victims of a nerve agent exposure. Nerve agents also have a mnemonic that describes their symptoms, and these are either the sludge syndrome or the dumbbell syndrome. In the top right-hand corner of the slide, you can see some of the basic symptoms involved in that. These are diarrhea, diaphoresis, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, and salivation. Essentially, the patients are very wet. They're excreting bodily fluids from every orifice, and eventually they have seizures. They appear quite ill, and the administration of an auto-injector quickly may actually help to reverse some of these symptoms and save their life. So these are the 4 types of life-saving interventions that will be available to you in our station. Again, if you can review these beforehand, you'll get a little bit more out of the station, and hopefully will be able to participate fully and get the maximum amount of benefit from what we're going to teach you. However, don't focus too much on learning specifics of how to do them all in detail. We'll go over that all during the course. Finally, look forward to seeing each of you on the 28th of April for our station, and if you have any questions or concerns about the station ahead of time, this is my email, john.broach@umassmemorial.org. Be happy to answer any questions by email ahead of time if you have any. Otherwise, we'll see you then, and in the meantime, take care.